The following is a news and public affairs presentation of West Virginia Public Broadcasting.
Support for this program is provided by the ECA Foundation. Learn more about the Foundation's work at energycorporationofamerica.com.
Life is an exquisite gift, but it's not permanent. You got to think about what you want for yourself and what you don't want for yourself.
It doesn't mean because you complete an advanced directives that you're going to die tomorrow, but it's for the future. It's for, you complete it while you're able to make those decisions for yourself.
Some want to go to the intensive care unit and be on a breathing machine and fight for every last moment. And others clearly say, I want to die at home and I want to be comfortable, and the last thing I want to do is be in the hospital at the end of life.
There's often a time when all of these advances in medicine are no longer our friend. They become the enemy when they make a person's life more difficult.
You're on your last chapter, and the majority of people, when you ask them, they know how they want that last bit of their life to be.
So Amy, tell us a little bit about your client today.
She has lung cancer. She is very independent still. I usually just go to have general conversation with her and do her hair. She likes her hair done. So I wash her hair and curl it, and that's about the extent of the care that she gets right now. She's still pretty able to do for herself.
But in just a few weeks, that will change. On a cloudy autumn afternoon, Amy Shoemake of the Hospice of Southern West Virginia is on her way to visit 73-year-old Joyce Cheesebrew. Joyce and her husband Bill have shared their home in Raleigh County for half a century.
I believe they've been married for 50 or 60 years. It's been a long time, and I'm sure it'll be hard when you're with someone for that long for them to eventually not be there anymore. It is very emotional. It is emotional for us, although we try our best, not that it always happens, because there are some patients that we get very close to, not to show emotion in the home, because, how can you be there for them if you're discombobulated yourself? There's many times a lot of us will leave the home. You go up the road, pull off on the side of the road, and just cry and cry and cry and cry. But we do the best that we can do to possibly help any way we can. We just deal with situations as they may come. Hello, good afternoon. How are you today, sir? Very good, thank you. Where's your beautiful wife at? Hi, darling. How are you doing? Good.
Joyce Cheesebrew has decided she will die at home. She's completed a medical power of attorney, a living will, and a do not resuscitate card.
120/56. Good, Dina. Yes, ma'am.
Hospice workers will visit weekly, daily, and eventually remain here around the clock to the end with Joyce and her family.
I think it's pretty nice that Amy comes in and does your hair.
I do too. I think it's wonderful.
Does she do a good job?
Yes.
They take pretty good care of you, don't they?
Yes, they do.
Can you tell me, Joyce, what it means to you to be able to stay in your home versus care in an outside facility?
It's more than you could dream, you know, because people don't want to go away from home, you know. They want to be in their home. And it's too good to be true, almost.
And so you find peace staying here, and you're at peace because you're able to stay
Right.
at home.
Mm-hmm. And that hospice is taking care of me.
Does hospice take care of the other members of your family too? Your husband, your children?
Yes. See, my son wanted me to us to come live with them. But we don't want to leave our home, you know. But we didn't know what else to do, really. And then somebody said something about hospice. I didn't know. I thought it was something you paid for, you know. And we didn't have a lot of money to pay for anything, you know, so I found out about it, and it's amazing. So God's looking out for me.
And how do you like to spend your days now?
I just do little things, little cleaning. I can't do big cleaning. But I just do little cleaning along. I used to quilt, but I can't do that anymore.
And you have family coming in to visit you?
Yeah.
Who's coming in?
My daughter and her husband tonight.
Well, Amy's pretty good at the curling iron.
She's the only practice I get.
Now you tell me. I had to start tipping you, Amy.
Having conversation with you and spending time with you is my tip.
It sure helps me.
I think another good thing with hospice is not only do they want to stay in their home, that yes, it may be the end, but they're still alive. They still want to live life. And when they're in their home, they can do that. They can do what they want to do. Every day is a blessing.
Yeah.
When your health isn't that good, it becomes very costly. And one good thing with hospice is they pay for your medications that are, you know, attributed to your diagnosis. So you're not looking at spending $400 or $500 a month on medication. You don't have to pay them to come into your home and spend time with you. You don't have to worry about, how am I going to pay this bill? How am I going to pay, you know, that bill?
Yeah, if you need the nurses, they'll come, you know. Just call them. You know.
24 hours a day we're on call.
Well, Joyce, you have children, grandchildren, and great-grandchildren. That's a lot to be grateful for.
It certainly is. And a husband at 54 years.
That's lovely.
What else could you want for? We've had our ups and downs, ain't we, honey?
Yeah, but hasn't been bad.
Nope.
Matter of fact, most of them been good.
Yeah. You can go in peace when you know, when you got that much.
There's perhaps not a more difficult subject to talk about with a loved one than death, yours or theirs. But healthcare providers and families who have found themselves in the middle of medical crises will tell you, not knowing what medical treatment your loved one wants and doesn't want at the end of life, or not sharing your own wishes, can have heartbreaking, physically painful, and yes, costly consequences. The good news is West Virginia ranks highest in the nation, with 50% of its citizens having completed advanced directives. Those include a living will, a medical power of attorney, a do not resuscitate order, among other directives available. But of course, the other side of that statistic is half of West Virginia citizens have not documented their end-of-life wishes.
With all that you know professionally, why haven't you made out your advanced directives?
That's a good question. There's no answer for that. It's just one of those things that people put off until the last moment, and the last moment comes and it's too late to do it.
Do you have a certain peace of mind now that you have made your wishes known?
Yes. Well, when it comes time to go, I don't want, things hooked up to me. I don't want to, when the doctor says that's it, it's in my medical power of attorney. My son and my husband both know what I want, and they say they will follow my instructions.
And we often don't think about that in middle age to make out those decisions.
We didn't think about it until I lost my mother and father fairly young. I was only 33 when my mother passed away, and she got cancer and very quickly went to where she didn't know what was going on. And we had to have her admitted to a hospice care unit in the hospital. And they had to ask us how, what her wishes were. And we hadn't discussed that with her ever. And my dad and my brother both looked at me like I was supposed to know. And it was a really hard decision to make. But I tried to go with what I thought her beliefs were and the way she felt, but without having that written down, it's you never know if you've made the right choice.
The discussions themselves are hard to begin.
Dr. Heidi Wareheim is a hospitalist, a generalist at Thomas Memorial Hospital in South Charleston.
Do you think that, on a whole, physicians, healthcare providers might shy away from that uncomfortable conversation?
Yeah, who wants to say, I can't help you? A lot of people are just uncomfortable about death in general. And to bring up the subject of death-related decisions and end of life, and I always say the last chapter of your book, it's, are we on the first page of the last chapter, middle page, the end? It's all debatable, but it's very uncomfortable, and we're not taught that in medical training. You are taught to just push forward to the end and not accept something that's just a natural process. We're taught how to rejoice at birth, but we're not taught how to make the end of life maybe not a rejoiceful moment, but a peaceful and happy and dignified moment.
Wareheim says that's when she relies on the trust that is developed between her and her patient.
Particularly as a provider, I know the patient well enough that I can say, I love seeing you, I love taking care of you, but this isn't the best for you, that you are at the end of this disease that we can't cure, and present the other options of like long-term hospice care. In the home, in a nursing home, things like that. That's an ideal situation when there's a relationship with the patient and the family, and we can look at where we're at with the disease and make plans from there so they don't have to spend their time in the hospital and getting poked in multiple tests, and everybody has a chance to come to grips with it.
Hey Cheryl, did you find that one test I was looking for?
I did. It's been granted.
Okay, so it's all been...
Dr. Bruce Foster is a family practice physician and chair of ethics and investigational studies at Thomas Memorial.
Where ethics comes into end-of-life care is it's all communication. You learn to talk. You learn to speak English. You kind of jump ahead of what you think what they need to know. My dying people, and typically wives outlive husbands, they know that this process is going to happen. They know that there may be this bloody mess. They know that this is what we kind of expect.
Because you've prepared them.
Yeah. And frequently, and when they come in and they come to their cancer, they come back from their oncologist, I don't say, well, how was your oncologist? I say, how was your visit to your cancer doctor? Okay, the cancer on your x-ray is not really getting smaller. I don't pussyfoot around. I use the nasty words, okay? And the wives frequently come up and say, that made me uncomfortable at the time, but I'm glad I knew.
Foster agrees there's an important component of medical training still missing when it comes to end-of-life care.
Doctors know medicine, they know the science, but they don't know how to speak English. What's mom's test? Oh, the ejection fraction's 14%. To the doctor, that's a fatal number. You have to say your heart's not squishing very well and your mom is dying. Many doctors don't know how to tell bad news. They'll kind of hem and haw. You'll see reports all the time, patient deteriorating, prognosis poor. No, the guy's dying. And by not telling people that they're dying, you rob them of a stage of their life that can be exquisite.
When I met you,
yes,
you explained things, can I say, down to earth? We don't have to be able to have a dictionary beside us. You know what I'm saying?
Well, I'm glad that you don't need a dictionary.
Because my daughter went to school and she'd say, Mom, help me with all the vocabulary. Of course, you know that speaking, you know, the words of the physician.
Yes.
But you broke it down. You gave us time, my family, to voice how they felt, what they expected, and you clarified. And you demonstrated in your kindness that we knew, I don't want to use it in a wrong way, but a two-face. In other words, you laid it down honestly and openly. She expressed much, and she let my children voice how they felt, and then they gave me understanding about the CPR.
Yes.
And it took a while, and after they expressed, Mom, this, how we feel, this what we can expect, and I got calm and I said, okay, Lord, and I let him take it off, that you will let him go peacefully, and that's the best way.
Good. All right, well, I'm glad that the conversation was helpful and that...
Oh, if there wasn't...
Teaching healthcare providers how to talk to patients and families about death, end-of-life medical options, and the importance of advanced directives is an ongoing effort at the West Virginia Center for End-of-Life Care in Morgantown. Dr. Alvin Moss is an internist, a nephrologist, and the center's project director.
Do you want to go to the hospital at the end of life, or do you want to try and be kept comfortable at home? Would you want to be put on a breathing machine in the intensive care unit, or would you prefer less aggressive medical treatment? Do you want intravenous fluids? Do you want antibiotics? Do you want a feeding tube? What is it you want? What is it you don't want? Now, of course, for patients to be able to answer those questions and for families to be able to answer those questions, they need to understand, well, what are the options and will a feeding tube help or not help? Will a breathing machine help or not help? And so there's our challenge to educate not only doctors but the public.
Moss says these are the questions that need to be considered and answered in advanced directives by all adults. The Center for End-of-Life Care distributes 50,000 of these forms a year, as well as providing information through its phone line and website.
We in West Virginia have a living will form, and we have a medical power of attorney form, and we have a combined form, which includes both. And the form that's completed the most in our state is the combined form. And once somebody's 18 years old, they can do a combined advanced directive that basically says, I want this person to be my decision maker if I'm too sick to make decisions for myself. And if that person is unavailable for some reason, I want this person to be my successor, my backup representative to make decisions for me. And then the living will says, if I'm terminally ill or if I'm permanently unconscious, these are the treatments I would want. These are the treatments I wouldn't want. And so what we find is most people, I was talking to you earlier and we were saying 3/4 of West Virginians say, really at the end of life, I don't want to die on machines. I want to be kept comfortable, and preferably die at home. And so somebody who has those values would want to do a combined living will and medical power of attorney.
These directives are also available in hospitals and physicians' offices. They do need to be notarized, but attorney services are not needed, and they can be changed or updated as often as the individual wants. When directives have not been documented and wishes are unknown, a medical emergency can tear a family apart.
Something traumatic happens or a catastrophic illness, end up in the intensive care unit, on a ventilator, can't speak for themselves, multiple family members, and it doesn't matter if this person is 20 or if this person's 90, it's the same thing. And we don't know who makes the decisions. You know, they haven't talked about which of the siblings is going to make the decisions. They have no idea what mom or dad or grandma would want. And then a lot of times you'll see internal disagreements within families.
Well, what do you do in that situation?
Mediate. I can't, my job is to mediate, to give information of where that person is physically, and then mediate decisions, sit with them and let them talk. And it's not easy. And that's not the time to be making the decisions. This is something that should have been made sitting at the dinner table with your family members when life is good and happy and you don't have the fear of the loss of someone.
Whenever I see a new patient, I bring up advanced directives at the very first visit. So it's a continuing conversation. Okay, so now that we've actually finished your exam, there's just a couple other things I want to talk about.
Sure.
Okay. I understand you were really sick in Louisiana.
Most definitely I was, yes.
You were on a respirator for...
I was on about 37 days in a coma in ICU on a respirator.
You know, what I want you to really understand is that I don't want you doing what I tell you, okay?
Okay,
I want
right.
it to make sense to you,
Sure,
okay?
right.
And you... I'm not the one in charge. You have the right to say yes. You have the right to say no. You have the right to say I want to do it and I don't want to do it.
Okay.
Okay?
Yeah, sure.
How can we empower the patient and family to get the information? It is not that difficult. It's really actually very easy. All you have to do is have 5 questions answered. And in words that you understand, not medical jargon. What's wrong with me? What are you offering me? What are the risks and benefits? What are the alternatives? And what if I do nothing? If I know those 5 things, I can make a good decision. That's essentially the elements of informed consent. Now, the only problem we've got is there might be a time when you can't tell people. Do you have a medical power of attorney?
At the present time I do, but I didn't.
You didn't back then?
Back in Louisiana, yeah, I should have, but I didn't have it.
The medical power of attorney form is the most important thing that you need. Okay,
Yes.
so you have somebody that you trust to speak your voice. If you didn't wake up and you had to go through all that again, have you ever thought about what you want to do?
Yes, I would definitely.
What I really recommend to sons and daughters, wives, relatives, is whatever question you feel uncomfortable asking, that's the one you probably want to ask. Okay. Oh, I don't want to get mom upset. Mom's dying. She is already upset. She needs to have someone to talk to. Okay. Oh, but I don't want to get my children upset. No, the truth is what people need. So talk early, talk often, talk frequently. If I was king of the world, what I'd have happen, let's say you're at a family reunion. And you go, hey, Tom, are you still going down to Myrtle Beach to that condo in September? Hey, Grandma, you still don't want that respirator if you can't be fixed? Just put it out there and make it part of the conversation. It would help demystify it. Okay. End-of-life things are scary. We don't know what it's all about. And that's okay. That's okay.
I don't know if you know what your wishes are this time. If you don't, the main thing is that we have the medical power of attorney, and the person that you named would be able to make that decision. And we could refer to medical power of attorney, and they can make that decision for you. But I would suggest that you talk to them and let them know what your wishes are.
Brenda Young is patient advocate at Thomas Memorial Hospital and routinely discusses advanced directives with patients.
You know, nobody's going to be mad at you if you refuse treatment or you accept treatment, and it's your body. You take charge of it. Or if you're the medical power of attorney, that's why you were appointed medical power of attorney, to represent your the person that has appointed you. Later date, or maybe
The hot pink form that Young reviews with a patient is the physician's order for the scope of treatment, known as the POST form, an innovation among advanced directives.
We're in the top 3 states in terms of having developed this form, and it's clearly working very well. If the doctor says to him or herself, I wouldn't be surprised if this patient died in the next year, then a POST form should be completed, because that then is the doctor sitting down with the patient, or if the patient can't make decisions, with the family and saying, are we doing CPR or not? And the doctor should inform them about the likelihood of benefit of CPR. Are we doing breathing machines in the intensive care unit, or are we going to do something that's not quite so traumatic? Are we just going to admit them to the hospital and do heart monitoring and oxygen and antibiotics, keep them comfortable, but not put a tube down their throat and put them on a breathing machine and tie them down because they're going to not like that tube in their throat and try and pull it out, and so they're in restraints, which is typical, unfortunately, for an intensive care unit setting. So the POST form is very helpful for patients who are clearly, or the doctors think, in the last year of life.
Moss says the Do Not Resuscitate card is still in use, but it's not as comprehensive as the new POST form. In fact, twice as many POST forms are now being filled out compared to the DNR cards. The last tool physicians have comes from the West Virginia Healthcare Decisions Act of 2002. It allows a doctor to appoint a family member as a healthcare surrogate if the patient has no medical power of attorney and did not complete other advanced directives.
Is there any change in her condition?
Not really.
When it comes to making those end-of-life decisions, medical providers say society often has unrealistic expectations of heroic measures, like CPR, breathing machines, and feeding tubes.
We love medical shows. I mean, just as a nation, we think they are great and they're so super interesting, and they're often so far from the truth. I wish Dr. House was at every hospital, and I wish that ER situations went as well as they did when ER was on, but I think we do get a false sense that if my doctor does the CPR and does the chest compressions and gives me this medicine and puts a tube down my throat, I'm going to come out of it and I'm going to be 100% normal and everything's going to be okay. And that's not the case.
We probably have more research on CPR and when it works and when it doesn't work than probably any other healthcare procedure or treatment. We know, for example, when somebody's having a heart attack, they're having their first heart attack and they've previously been healthy, that person has a 50-50 chance of benefiting from CPR and leaving the hospital and doing pretty well. Or if somebody has a drug overdose, they've overdosed on a drug and they're in the emergency department and they stop breathing, they have a 25 to 50% chance of being fully recovered and receiving further treatment, but CPR is likely to work in that situation. Or if somebody has their heart stops in the operating room, again, 70-80% chance that they're going to do well with the CPR and that they're going to be able to carry on with their life. On the other hand, if you take all people who have their heart stops in the hospital and they receive CPR, only 1 in 6 survive to leave the hospital.
The majority of people who arrest have an underlying or multiple underlying issues that, because of the lack of oxygen, because of the lack of blood flow, because of the breaking of the bones, it just compounds an issue a lot of the time. And, the general public, were not exposed to what happens during a resuscitatory effort. And it's a very difficult thing for a person's body to go through. And especially when you are an elderly and frail and you don't have a lot of muscle mass, you have thin bones, you already don't have a lot of blood flow to your brain. The sequelae, or what comes afterwards, is just sometimes worse than what we started with.
If there's nothing in writing that says don't do the heroic things such as CPR, life support, and if, say, a mother has a terminal illness such as pancreatic cancer, maybe it's spread to the liver, a feeding tube is not going to change the outcome. A life support is not going to change that outcome. Or if it's lung cancer and there is no further treatment, you place someone on life support, does it change the fact that they have the terminal illness? No. A lot of times it's the terminal illness that causes them not to be able to breathe or not to be able to eat. So you have to look at, is this what they would want? I mean, we can offer a lot of things and we can do a lot of things to people, but are we really doing it for them?
I'm just going to listen. Now listen. We're supposed to be a benefit and do no harm. That's part of the Hippocratic Oath. And when we have this patient who's very sick with widespread cancer, who's not responding to chemotherapy, who's in the intensive care unit because their disease has gotten worse and worse, and nobody's had a discussion about, well, if it got that bad, would you want to be on life support? And so we end up coming in and we can say, you know, the oncologists have told us they don't have anything else to offer that's going to stop the cancer, and the cancer has now caused your lungs to fail, and you're, you know, or we'll say this to the family, and your loved one is in shock on a breathing machine because of the cancer. We can be fairly certain that keeping the patient comfortable is the best course of action at that point.
I'm letting him make that decision, what he wants to go through.
Okay. All right. So did you hear that? Sort of, you know how the buck stops here.
Yes.
So she's going to let you decide if you want to try more chemotherapy or not. When you took it in 2003, it worked well.
Yes.
But you're not quite as good as you were in 2003, are you? Not quite as strong. You've had, what, some heart attacks and some heart trouble along the way, right?
Strokes.
And some strokes. Okay.
You had said that if he goes to the skilled nursing unit and he was not, you know, he wasn't, you know, doing well with physical therapy and those things, if he was declining rather than getting stronger, you still thought about taking him home with hospice at that point too.
Right.
Okay.
The work at the Center for End-of-Life Care is based on the medical specialty of palliative care. Moss says that's appropriate when a cure is no longer likely.
We're not giving up on the patient at all. We're being very aggressive, if you will, intentional in our treatment. It's just that the goal of our treatment has changed from doing as much as we can to cure the patient to doing as much as we can to be sure that the patient is comfortable, okay, and has as good a quality of life as we can provide for the patient. So palliative care is working with the patient and the family to identify their wishes, to treat their pain, to treat their symptoms, and to try and ensure that the patient has the type of treatment that the patient wants. So it's a very positive thing. Sometimes doctors think, oh, we won't consult palliative care, that's giving up. Well, it's not giving up, it's getting good communication to try and figure out what would the patient want at this stage in their life with their condition.
It's nobody's business that we have anything to hide.
There you go.
You got all your pills? You still taking
Yes, sir, I am.
Dr. Foster is Director of Palliative Care at Thomas Memorial, one of about 10 palliative care teams located in hospitals throughout the state. His entry into palliative care followed his father's diagnosis of cancer.
In my medical training, I had zero amount of what to do with a dying patient. Matter of fact, I was taught that the death of my patient was my failure. So my daddy was kind of a pragmatic type of fellow. He's sitting on the side of his bed, and he goes, okay, what's wrong with me? I can't tell my daddy's going to die. I don't know how to do this. So I said, Daddy, you're about as sick as you're ever going to be. And he goes, what in the heck does that mean? I said, you're eaten up with pancreas cancer and it's going to kill you. When he watched his back arch, I said, I got to come up with a different approach. Very simply, what I decided to do was tell him the truth in words he understands, put my feelings aside, because he's the one with the problem, and support him. Any other questions for me?
That's it, Doc. It's been great. Good to see you again.
Say hi to your wife. So with palliative care, what we're trying to do is improve quality and let the person kind of direct how much quantity they want.
And just because you get a palliative care consult doesn't mean that you're stopping everything. Oftentimes, sometimes we'll determine, no, the patient would want to continue, or we may put in place a time-limited trial of treatment. So we may keep on going for a while, and then if the patient benefits, that's great. We have cases that we sign off of all the time where we sat down with the family, we said, let's try it, let's give it a period of time, but if it's not working, then we'll stop, and it worked, and that's great, and we're all happy. But then there are many cases where we try it and clearly mom's getting worse and mom's suffering and everybody can see it. And then we say, let's just make our main goal now keeping her comfortable.
The goal is to get the patient where they want to be. I would say 1 minute is a lifetime for somebody that's dying, or an hour. You know, we take it for granted, but if it's your last moments of life, you know, you want to be where you want to be. And we try to honor that.
It gives you an opportunity to recognize that I'm dying, I'm preparing for death. The majority of us want to be happy. And the majority of people, when you ask them, they know how they want that last bit of their life to be. And that's all part of palliative care, and then helping support their wishes.
So at this point, we're sort of trying to figure out, where do we go from here? What would he want? Okay.
He wants to go home.
He wants to go home. Okay. Now, I think you understand and he understands that at this point, we're not going to get him off the breathing machine. He's going to need to be on it at least a part of the time, right? That was obvious, because last weekend they tried to have him go all day without the breathing machine, and he got into trouble.
Yeah.
So you would like to take him home on a breathing machine, is that right?
Yeah.
On a breathing machine. And then it's a matter of working with your insurance to see if that can happen.
Right.
Now, previously, they've not been very receptive to that, have they?
No.
Okay. But from what I understand, and Heidi, maybe you can help us with this, you've looked into the possibility of if even maybe hospice could help him go home on the breathing machine. Is that right?
Well, we haven't checked with the agencies, but Teresa and I have talked about that could possibly be a
Right.
route.
Okay.
When we were looking at all our options. Yeah.
And you understand that hospice means that somebody, on average, has about 6 months to live. You know, that the prognosis is not good. Now, that doesn't mean you might not get better than that, okay? 20% of people who go on hospice come off hospice because they've gotten better, okay? But what it would do for Teresa is it would provide a nurse on call to come into the home to check you, somebody you could call if you were concerned about how he's doing. Plus, they'd provide hospital bed, and they'd provide the supplies and the equipment, and you know what I mean? So it would make your life much easier.
Yeah.
We also made the decision that if things got so bad that if, despite being on the breathing machine, you know, your heart were to stop, you would want us just to keep you comfortable at that point, right?
Right.
And we made that decision because we knew if it got that bad, CPR wouldn't help. Shocking his heart wouldn't. We're already breathing for him, right?
You're right. Yeah.
That's right. Okay. What questions do you have about where we are right now?
Just the questions is, can I handle him at home? Can he be okay with me
Sure.
handling him at home?
Right.
Because I don't want to do anything to hurt him.
Yes. So what we're going to need to do is look and work with your insurance company, and we'll try and find a hospice and see what services are available, okay? That's what we're going to have to try and do, is put a plan in place so that it doesn't fall only on your shoulders,
Right.
okay? So Denley, is that plan, I know you can't talk because you've got that thing, you know, in your throat, but does that sound good to try and get you home? Yeah, okay, that's what you want. Okay. Good.
Sometimes, you know, in your journey in life, even when you drove to our hospital, you took the best possible route. You did not walk, you did not go through the woods or, you know, off some roads. You probably took the interstate in the best route. So sometimes in life, it's a destiny, it's a journey, and it depends on how we get you there. You know, we can continue to do a lot of things, a lot of tests, a lot of needle sticks, a lot of. But if we know the end result, we're still going to end up, our demise is going to still be the same, or the destiny is still going to be the same, then, you know, you might not elect to go through all these backwoods to get there. So, you know, the journey could be a lot smoother.
The cost of end-of-life care in intensive care units like this one at Ruby Memorial Hospital in Morgantown can be staggering. For treatment many healthcare providers say is often unwarranted, painful, even inappropriate. Defensive medicine, ordering procedures that may not be strictly necessary, but done in fear of medical malpractice suits, adds to the skyrocketing healthcare expenditures. Providers believe this could be curbed with greater use of advanced directives. Medicare alone currently reports paying close to $67 billion a year on chronically ill patients in the last 24 months of life.
Something like half of that is spent in the last 2 months of life. We put lots of people on machines in intensive care units at the end of life, when if we would have had the conversation that I just described with you, 3/4 of those people most likely wouldn't be there. And so we could save millions and millions of dollars, billions probably. I like to say it's a win-win type of thing. The patient gets the treatment that he or she wants, and we don't spend all the money that we can't afford to be spending. The baby boomers are coming, okay? The demographics are against us, but yet we need to have the conversations so that we can stop using the intensive care unit as a surrogate for providing end-of-life care.
I've always read. My grandmother told me that theoretically everything that was ever wrote by a man's wrote down somewhere. So if you just read and read and read and read everything you can get your hands on, theoretically you'll know everything known to man. And it was an idea I could just never get away from.
Joe Phillips of Fayetteville chose to come to the Bowers Hospice House in Beckley while battling the final stages of pancreatic cancer.
I've got an NMR, no medication or resuscitation. I understand that most of the people that come here already have one. It's just something I would advise. With me, it's a whole quality of life issue. If you can't think and participate, then there's no real quality of life. It's always a hard decision. You're being faced with something that you're just not geared to think about. And that makes it very personal.
The staff here told me that you were eager to talk to us. Can you tell me a little bit about that?
Well, this is a really nice place, you know. I usually wind up saying for what it is because it is a terminal care facility. You don't normally come to a place like this expecting to walk out. So, you know, you got to sort of say that it, you know, for what it is. But it is a really nice place. And they take good care of you here. You've got the birds and everything out here. There's geese that fly over all the time. And you've got just the peace and solitude, you know, to get yourself right and make sure that you're ready for what you came here for.
Are you at peace, Joe?
I'm really don't think you get that till, you know, it's just like really thrust on you. I'm as close as I can come, I think. I work on it some every day.
This just has to be an incredibly hard thing for you to see your mom go through this.
Well, I'm the one that told her and Dad, you know.
You have both of your parents.
Yeah. And you never really think you're going to bury anybody in your family, much less your son or daughter. So that is, that's hard. But Mom and Dad are real close in the church. I'm not so much religious myself as I am spiritual, and it has helped them. And like I said, they're coping.
What do you focus on at this time?
Well, one of your guys was telling me it's a beautiful day. And I said, yeah, anytime you can get up and see the sun, it's a beautiful day. And doesn't necessarily have to be sun out there. Because you know it's there to begin with. That makes it a nice day.
Hospice of Southern West Virginia serves Raleigh, Wyoming, Summers, and Fayette counties. Its in-home program serves 500 families a year, and now it can care for up to a dozen individuals and their families at Bowers House, its new inpatient facility.
When we meet with families who have a loved one that needs our care, We tell them that we don't do aggressive curative care, but we provide very aggressive comfort care. We take that very seriously. So we will do any medication regimen that is helpful to a patient. We administer oxygen. We can administer feedings as it is appropriate to do so. But from the palliative care and hospice approach, we feel we do a lot.
What financial responsibility does an individual have as they enter the hospice?
Well, for the hospice service, essentially there is none. We accept Medicare and West Virginia Medicaid payments, and then we also accept indigent patients. We're a nonprofit hospice, so we take into account that there will be people who have no means to pay, and we still provide care for them as well. So related to their end-of-life care, there will be no cost.
What about emotional, psychological care?
Right, well, it can be very stressful for a person to come to terms with facing the end of their life, and so we provide some emotional support. We have a staff of social workers who can meet with patients and families, and basically what we do is just help them speak to each other, help them talk about things that maybe are a little difficult to talk about if they choose to go that route. We have pastoral care as well, because at the end of life a lot of people review and they look at spiritual matters, and so we make sure that they have access to a pastor. We have several pastors in the community who volunteer to go out into the homes and to come here to this facility to meet with people. So we're providing an emotional, a spiritual support. We're helping caregivers vent some of their concerns and fears in facing losing a loved one. And then we'll also provide bereavement support for 13 months after a patient passes away. We'll follow their family for 13 months with bereavement support through phone calls, some literature that we mail to them regarding grief and what they may be experiencing. So once someone passes away, we don't forget about those people that cared about them the most.
My father was born in Raleigh County. My mom was born in Ingo County. But they met in college and were married, and both were school teachers for, I think, Dad 38 years and Mom 37 years.
Bob, you've told me that it wasn't too long ago that you lost your father.
Yes.
And so returning here has to be, with your mother, really very bittersweet, I would think.
Bittersweet is a very good way of putting it. Yeah, because the first time we weren't sure what to expect. But the second time, I knew all the people. I knew just what the process was going to be. And it makes it easier in a sense, but it's still a great loss.
They make it very clear to us what's going to happen next and next and next. And the direction they've given us and the care has just been absolutely awesome. So it kind of takes the burden off the family, knowing that you have that much support and people who know what they're doing and making it the best they can make it for your loved one. It's comforting to know that those services are available. There are things that we couldn't do at home, no matter how hard we tried. We could not care for the people like they do here.
The medical power of attorney, the living will, any of those, were those decisions that had been made and talked about?
Yes, all of our families talked about that, and all of us have opted for no special measures or no resuscitation and organ donors. But that I think that's a very important or critical decision for a family, because there would be a great deal of uncertainty if you had to make some certain choices, if you had to decide whether to give transfusions or feeding tubes, other choices, if you didn't have that directive.
I guess one thing I would like to let people know is you can't take care of these things too soon. I mean, people can become disabled and in a coma at 24. You know, you've got to study this. You've got to sign the papers, let people know what you want, and do it soon. Because then the burden's taken off the family.
lung cancer, stage 4. It spread to my liver, my bones. I am terminal. And I got a few months ahead of me, not too long, but a few months ahead of me. And I'm blessed to be here.
Kevin Brown grew up in Raleigh County and has been back and forth as a resident of Bowers House as his cancer has progressed.
When you first find out that you get that kind of news, that you're terminal and you have cancer and stuff, it's like a bomb going off your life. And you got places like this you can come to and make peace. My medical power of attorney is to see that my wishes will be carried out. There are no feeding tubes, no life supports, no tubing or anything like that. I'm just to be kept out of pain, left in peace.
Was that a tough decision to make?
Yes, at first. And DNR did not resuscitate. I don't, once God calls me on to be let go. I don't want to be brought back. It's cancer, it's a battle. It's a lot of painful, and it's painful. And I don't want to be brought back to suffer more.
Tell us how you want to live the rest of your life.
I want to be happy. I want to spend what time I can with my family and friends. I just want to be pain-free and be ready when God calls. And I want to be here.
And I understand there's still plenty moments of joy.
Yes.
The staff here tells me that you had a mini party a couple days ago.
Oh yeah, yeah, the Halloween thing. We had a mask they brought in, and I've laughed the most since I've been sick this past week. They brought in a Halloween mask, and we scared each other and stuff like that, and a couple nurses dressed up, and we had a great time. I mean, it's great. It's not sadness, it's laughter and everything, and I did their best to make your joy, to make you laugh when you come in and everything, and it was worth a lot, and it meant a lot. And it's a real joy to know there are people out there that care to reach out like that to help you. And it's not all about dying, it's about living and being happy in your last days.
You getting all settled in your new space? Yeah. You'd probably be surprised to know that it can be a wonderful and satisfying experience. Speaking to you, I'm a social worker who's been in healthcare for close to 15 years. Probably 5 years ago I would have told you that hospice was not the place for me. But I have really enjoyed this work, and it's a beautiful thing, and it's a very satisfying experience to be a professional on the outside, but also to see families come together. We don't cure people, but we see a lot of healing. We see a lot of families coming together where there may have been rifts in, between relationships, where the being faced with the dying allows people to heal those relationships. They can come together, they can remember things from, if it's brothers and sisters who maybe haven't spoken for years, they can get together and talk about their childhood and reflect on their parents. And so we see a lot of healing here.
Three-quarters of the people who die in this country are over the age of 65. And so with a very old population, these types of decisions are even that much more important to do in advance.
It's involving the patient, involving the family, involving their friends, involving their religious or spiritual issues. So you have a whole package that's making the decision.
And there's some peace to be had when this information is available ahead of time. And so I guess the biggest thing is don't be afraid to bring it up. The conversation will flow.
Support for this program is provided by the ECA Foundation. Learn more about the Foundation's work at energycorporationofamerica.com.
The preceding has been a news and public affairs presentation of West Virginia Public Broadcasting.